So my talk will be essentially an overview about COVID-19 vaccines, where their approval status lies, touching on some of the questions that you all have asked in advance of this meeting regarding vaccination, and just ending very briefly with some additional CDC guidance about protecting children going back to school and other therapies. So next slide, please. So these are the questions that I will address throughout the talk that have already been brought up. So how do we know that vaccines are safe? When will the vaccine be ready for children under 12? Why don't the vaccines have full FDA approval yet? Which I can gladly say they do, at least for some age groups. Does someone who had COVID still need the vaccine? How can I protect a child who's too young for the vaccine? Does it matter which brand of vaccine we received? A question about protecting your child when family members haven't been vaccinated and have regular contact, and things about safety and sending children back to school. Next slide, please. COVID, so I'll start to discuss a little bit about COVID vaccine, the development, the background, and where the status is for development of pediatric vaccines. Next slide. So here's sort of the 4 major vaccines that we have been using in the United States or that are on the radar in the US. Pfizer being the major candidate and the one that I'll talk the most about today, just because it has a little bit of a leg up in terms of timing over the other vaccines. So as you all likely know, Pfizer has been officially fully licensed by the FDA for individuals 16 years of age and older. And has been released by Emergency Use Authorization for a younger age cohort, so those that are 12 through 15 years of age. There is a phase 2, phase 3 trial that has been ongoing and enrolling since mid-June of this year, and I'll talk a little bit more about that in subsequent slides. The other vaccines that are sort of in the queue include Moderna, which has been approved for by EUA for 18 and older, and an EUA has been filed for those 12 and older, but not yet authorized. So that happened in mid-June. So I would honestly be expecting news on that any day. They also have an ongoing study in 6-month to 12-year-old children called Cova, that's similar to the same population as Pfizer with a similar study design. The other 2 vaccines, the non-mRNA vaccines, which are Johnson & Johnson and Novavax, both have some plans or mention of plans to study in the pediatric population, but haven't really gone down the road of enacting those trials as of now. Next slide, please. Next slide. Okay. So first question, or one of the questions again, is one of the brands of vaccine better than another? So this is a nice table that I found on a local medical website that breaks down the different vaccines that are either authorized or approved, their dosing, their age ranges, effectiveness, and in particular, effectiveness against disease on the bottom row. So as you will see, looking across that table, for effectiveness against disease, which is symptomatic COVID-19, not just presence of the virus in the nose or in the saliva, but actual, even the sniffles counts as symptomatic disease. Is pretty good. So for Pfizer and Moderna, it's 95, 94%, and even 86% in the elderly population, which is very good. Slightly lower in the J&J and AstraZeneca, Novavax vaccines, but still very good. And all of the vaccines are 100% effective against death, which is very important to keep in mind. No matter what it is, protection against death is robust. And even minus the symptomatic COVID, in the setting of Delta, there is still protection against infection and symptomatic COVID as well. So a lot of questions about the Delta variant being different. Why is it transmitting so much? Why is it causing so many problems? It does have slightly different structure, but still there have been studies with the Pfizer vaccine that have demonstrated 72 to 79% protection against infection and still 87% against symptomatic COVID-19, which is excellent. So really, any vaccine is great, whatever you can get your hands on. They all do a great job for protecting you from negative outcomes. Next slide, please. So how do we know the vaccines are safe? This was a big question that I think we got repeatedly, actually, and I have gotten personally as an infectious diseases physician and someone who, full disclosure, used to work at the FDA and the Center for Biologic Evaluation and Research, which is the center that regulates vaccines. So I will touch a little bit on how vaccine evaluation is done, just to give you some background in case this is something you have never heard before, and then talk a little bit specifically about the COVID vaccine. So vaccines go under very heavily scrutinized clinical trials that are very large. We're talking 30, 40, 50,000 people. And beyond that, real world data has been able to be obtained from those that have received the COVID vaccine. The VSafe program, there's various different clinical safety mechanisms. So we have tons and tons of data telling us that these vaccines are safe. Next slide, please. In a more structured way of going about this, this is how we ensure that vaccines are developed in a safe, well-regulated approach. So this is the model that the FDA uses to move from development of a vaccine or a substance in a lab, testing it in animals in those preclinical stages, moving through phase 1, which is the primary safety testing, phase 2, which is safety and immunogenicity, which really says, does this make an immune response? Phase 3, which tests the efficacy, and then the official licensure. And what I'd like to point out is there are additional phases after that licensure. So continued data collection, looking at safety, changes, adding of new indications, new age groups. But really a big thing is historically, this process has taken 10 to 15 years to develop, which is probably something you've heard. I am going to touch on why this has been faster for the COVID-19 vaccines and why I expect that in the future, actually, it probably will be a quicker process as well. Next slide. So briefly touching on the phases, again, as I mentioned, phase 1 of the vaccine development process is answering the question of preliminary safety. These are the first times that vaccines are used in a human population. So they're done in a very small group of individuals, usually on the order of a dozen or 2 dozen, and really looking at, if I give this to somebody in their arm, is it going to cause any negative side effects? Is it going to be tolerable? Usually these are healthy adults. Again, it's not a placebo comparative trial. It's really just, what does this do when I put it in someone, and can other people tolerate it? So once that is progressed, then we move on to phase 2. So next slide, please. As I mentioned, in phase 2 studies, there are larger number of individuals in this, and you're really starting to look at, does this vaccine cause an immune response, which typically is measured by antibody levels in the blood of the subjects that receive the vaccine. It also has additional safety data collection. So we're talking typically hundreds, if not, a few thousand patients in this phase of the clinical trials. And we start to get into the randomized and more well-controlled studies. Again, mostly healthy individuals, but oftentimes you get a few more folks that are targeted towards your sort of ultimate population. In the case of the COVID-19 vaccines, that would be everybody. So you may get a few more high risk individuals in this group instead of just young, healthy, 20, 30-year-olds. Next slide. And then phase 3, this is where the money is. This is what we would call a pivotal trial. So phase 3 trials vaccinate huge numbers, as I mentioned before, 30,000, 40,000 subjects in a randomized controlled, meaning there's a different agent, a placebo or standard of care vaccine, depending on what trial or what product you're looking at, and looking at not only the immune response, large volume of safety data in that giant study population, but also looking at your actual clinical efficacy. So this is the phase of the trial where we answer the question, does this vaccine actually protect from disease? Because if a vaccine creates really great antibodies, but you still get the disease, what's the point? In the end, what we care about is the clinical disease endpoint, preventing and things that go along with that. So preventing hospitalizations, preventing deaths, preventing other sequelae. So this is the meat of the trial, and this is why this is the most heavily scrutinized and well studied. And we'll touch on that, where that is in the pediatric vaccine pipeline at this time. Next slide, please. So I won't spend too much time on this, but I just wanted to highlight that there is a difference between emergency use authorization versus official licensure. So official licensure has been the standard for approving vaccines for use in the general public. But starting in the early 2000s, in the wake of 9/11 and concerns about terrorism, in particular the anthrax attacks, the FDA, CDC, and industry came together to create a mechanism to allow use of medications for novel reasons or novel medications or devices in an emergent situation. So that's where the EUA was created. It is a temporary and only reserved for the highest risk situations where some immediate action, something that potentially has benefit for the population that far outweighs the risks is available. So other examples beyond the COVID-19 vaccine included the use of ciprofloxacin, which is an antibiotic for anthrax. It had not previously been approved for that use, and use of certain masks, certain respiratory devices in the H1N1 pandemic back in 2009. There is still a minimum amount of data that's required. And generally speaking, that's 2 months of continued follow-up safety and immunogenicity data after the last dose of vaccination, as opposed to the longer term follow-up that we do in the standard studies. And ultimately, the full compilation of data is required. And so that's what we've continued to see with the Pfizer adult vaccine as time has gone on. And all of that data, as I like to point out in the EUA, is still independently reviewed by FDA reviewers. So they are working on a compressed clock with, yes, a little bit less volume of data, but still looking at vaccine immunogenicity reports and redness, swelling, arm pain reports from 30,000 individuals. So that is a huge undertaking that they do in 3 weeks to a month, and is amazing work. Next slide, please. So just want to give you a glimpse. We talked about EUA, talked about full licensure. I'm actually going to skip this slide. Let's go ahead, next slide. So as I mentioned, we're in the clinical trial phase of the Pfizer vaccine for healthy children less than 12 years of age. This is a phase 2, phase 3 trial. Because we have a lot of robust adult data on the immune response, they don't need to enroll quite as many kids. They can do some comparisons through statistical methods to say, well, if we have this proportion compared to this proportion, are those things equal? So as a result, they ended up only needing to use 4,600 children instead of 46,000, but still have a comparative arm, still comparing placebo to vaccine, and looking at different age groups because children are not just small and smaller adults. So there are 3 age groups: the 5 to 12-year-old age group, which has recently been expanded to include additional children for additional safety data collection, the 2 to 5-year-old group, and then 6 months to 2 years. Something that I'd really like to highlight is that in all of these groups, lower doses of vaccine, of the actual RNA vaccine product, have been recommended based on early phase 1 studies where they discovered that you could give lower doses, get the same immune response, same clinical protection, and have less reactogenicity. So less aches, less pains, less arm redness, all of those good things. So that's why it's especially critical to think and see these trials be completed, because you're using a third of the dose in the 5 to 12-year-old group, and you're using a 1/10 of the dose in the children less than 5 years. Next slide, please. So just one more kind of key safety point I like to make about vaccines in general, because I think there's been a lot of talk about, the rushing and wanting to wait and see for results and being concerned about the risk versus the benefit. So all phases of vaccine development have been completed for the COVID-19 vaccines. Some of them were done in parallel, some of them were compressed, some of them were overlapping, but everything has been completed. We have massive amounts of data that all suggest and actually tell us that adverse events, while common, were mild and transient, the vast majority of which resolved by 7 days post-vaccination. And as stated, we continue to get data in every day from those that are getting the vaccine, not as a part of a study. And as you get more and more and more people vaccinated, you are going to detect some rare events that may or may not be related to the vaccine, but happen through sheer circumstance in temporal relation. So those are things that occur, 1 in a million, things that we've been seeing like the myocarditis or Guillain-Barré and the J&J vaccine that are extraordinarily rare and remain extraordinarily rare in vaccination. And the last point I like to make is when people talk about long-term risks or risks associated with vaccines is there was a study looking at the VAERS vaccine safety database information about death following vaccination, historically looking back at all vaccines, and the risk of death following vaccination, so no causal relationship, but just within 30 days of vaccination, was 0.0001%. If you compare this to the risk of getting COVID, even in the youngest, healthiest population, you're looking at 0.01% to 1.7%. So that is a huge increase in risk of death from COVID, even in the healthiest, youngest population compared to vaccination. Now, yes, there are other effects, other sequelae that we worry about, but if you're just talking about death, it's sort of a no-brainer. Vaccine way better than COVID. And last point on this slide is that, again, looking historically at other vaccines and what we know about the COVID-19 vaccines, almost all, I'd say 99.5% of all vaccine reactions and side effects happen within 28 days of vaccination. So well within that period of the most intense study, scrutiny, and well beyond what we've seen in the vast majority of the people that have been vaccinated to date. Next slide. So I won't belabor this too much because I know I'm taking a large amount of time, but a few reasons that COVID-19 vaccine development has been able to be quicker than other vaccines in the past include the use of new technology. So the mRNA platform is much more rapid than more traditional techniques that involve growing viruses up in cells that have been obtained from animals or grown up in a lab. So it's more of a plug and play technology, so much more rapid to tweak the vaccine as you're learning about it. And there is experience with this type of vaccine in previous studies of coronaviruses. So if you remember SARS in the early 2000s and MERS, a few years later, both of these actually had phase 1 clinical trials for mRNA or DNA vaccines that were performed. Unfortunately, or fortunately, I guess, both of those viruses and syndromes sort of burned themselves out. So there was no disease to test against for the later phase 2 and phase 3 studies. So they kind of stayed in phase 1. But there was preliminary safety data and data about how to make these. So that really helped give a leg up for the COVID vaccines. Another thing that has helped is that there's been massive cooperation throughout the scientific and medical community. So basically everyone in the world, at least for the first year of the pandemic, was working on COVID. And that was it. And sharing this data at an unheard of rate, free publications, that has really helped with the development of the scientific aspect. And the third piece that's really helped with vaccine development is the financial offloading of risk. So things like Project Warp Speed and other financial support with collaboration in the industry has allowed vaccine makers and sponsors to more aggressively pursue vaccination without having this risk of, well, if I spend billions of dollars to make this and it doesn't work in my phase 3 study, am I completely sunk? So they don't have to worry about that. They don't have to be quite as reticent with their risk taking and can move forward. Next slide, please. So this slide just demonstrates where that money piece plays in. So if you look at this, it shows the timeframes or goal timelines for COVID-19 vaccine development in each of the various phases and aspects of vaccine manufacturing. And then the gray bars are what it would be in a typical vaccine. And so the biggest areas, again, where this timeline has been able to be shortened are in the areas of academic and preclinical research. As I mentioned, massive collaboration globally have helped really speed up this body of work. And then the two biggest financial risks. So building factories to help develop and create the vaccine and manufacturing the actual vaccine and assays and other things. So instead of having to start from scratch with all of these, there has been agreements to use existing factories, existing facilities, existing technology, and that has shortened that by a decade, I would say. So really minimal changes to the actual human trial phases in terms of length. But it's these other factors that have really sped up our ability to study this vaccine. So next slide, please. So here's like the money question. When will the vaccine be ready for kids less than 12 years of age? This is what everybody wants to know. Everyone on Twitter is starting a riot over it. Next slide, please. So I'm going to tell you right off the bat, no one can give you a hard answer to this question. However, I can show you the pattern that the Pfizer vaccine has taken in development thus far and give my best optimistic guess. So if you look, particularly when the phase 2, phase 3 trial for adults finished, which was November 2020, and when the EUA was first granted, which was December 11th, 2020, that was about 3 weeks apart. So 3 weeks from when they had their final data set, were able to submit it to the FDA. The FDA was able to look at it and then say, yes, this is okay to use. That was about 3 weeks. If you look at the 12 to 15-year-old group, there's a little bit wider time frame. So their phase 3 results came out in March 31st with an EUA for that age group May 10th. So more like 6 weeks in between, because there were additional safety considerations that applied more broadly to all COVID vaccines that kind of got wrapped up into that. But so you're looking anywhere between 3 to 6 weeks in terms of that, finishing the data and review for EUA. So where that lies is this is a little bit speculative, but the first children were enrolled in early to mid-June in the phase 2 to phase 3 trial. And based on the length of trial, we know that there are 2 doses of vaccine, 21 days apart, so that's 3 weeks. There are 2 months of data collection afterwards, so we'll add an additional 8 weeks. So that would put it at 11 weeks, which would be about September-ish. So we are looking at likely the data set being complete from that initial group in the next week or so. Caveat being that I know Pfizer has asked for additional subjects to be enrolled for additional safety data. Whether or not that will delay EUA remains unknown. In that case, they were looking for 4 to 6 months, which would definitely prolong things. But I have a feeling, they could decide that they would like to approve it and continue to collect that data so that they have that under their arms and can use that to change course if necessary. So if you click, please, next slide. My best guess by sort of time frame, would be potentially Halloween, end of October, early November for at least the first age group, which is the 5 to 12-year-olds. Obviously, there are a lot of things that could change, but that's sort of where I see this potentially going. So another month and a half or so before we might have an EUA for 5 to 12. Okay, a few more questions. So someone asked if they already had COVID, do they need the vaccine? And that is a resounding yes. So COVID reinfections can and do occur. And in particular, in the setting of new variants, we've been seeing lots of people who initially were sick with COVID with the Alpha variant, as we're calling the original, back in March, April, May 2020, now also having the Delta variant. Natural immunity, while likely somewhat protective, is not 100% and is variable in different individuals, and in particular in immunocompromised persons. And I know that the later presenters will touch on this a little bit, particularly for this population, that's the audience today, but that is something to take in. And then another thing to remember is that quantity is not the same thing as quality. So just because there are high antibody levels in someone's blood does not mean that those are neutralizing antibodies, does not mean that they attack the virus or protect fully against disease. So all of these things are reasons to not necessarily rely solely on natural immunity. And there have actually been studies that have looked at this question. So there was a study recently in Kentucky through May and June of 2021, and they looked at all previously infected individuals in the state that were in their database and followed them for those 2 months. And they found that unvaccinated, previously infected individuals were twice as likely to be reinfected and end up hospitalized or symptomatic compared to fully vaccinated, previously infected individuals. So this supports that even if there is some protection from previous infection, there is a boost and improvement of protection, particularly against severe disease, hospitalizations, and death with the vaccination. Next slide, please. This is just a great graph that I think really visually hits this point home. So it shows the difference, all comers, between hospitalizations in fully vaccinated individuals, which is the green line at the bottom, and unvaccinated individuals, which is the blue line that is sharply trending up. So that really captures the difference in hospitalization with and without vaccination on a population basis. Next slide. Okay, so the last couple slides, just going to wrap up, shifting gears away from the vaccine to talk about therapeutic options and some of our non-medical interventions. Next slide. So this is something that I wanted to touch on because I think it's underutilized, and likely because a lot of people don't know about it or don't really know what the deal is and what's required to receive monoclonal antibody therapy. So currently there is sort of one recommended cocktail of monoclonal antibodies, and I'm just going to call it by the brand name, which I hate doing, but good luck saying these other MIBs and MABs, although y'all probably have better practice than I do. So Regeneron is what this is called. Regeneron currently has an EUA for individuals 12 years of age and older and weighing over 40 kilos. And there have been multiple studies supporting the really impressive efficacy of this monoclonal antibody cocktail in preventing hospitalization from SARS-CoV-2. So currently there are sort of two ways that this medication can be used. How we have traditionally used it in our institution is if someone presents with a positive SARS-CoV-2 test within 5 to 7 days, typically, they are not anticipated to need admission at that time. So they can't be needing oxygen immediately and fall into one of the high risk for severe disease categories, which are listed on the slide, but wanted to highlight immunosuppressive disease and treatment. So likely most of the kids and families were worried about in the audience, this would be applicable to you. Or more recently, this has actually been authorized for use as post-exposure prophylaxis. And that can be in anyone that is immunocompromised or not fully vaccinated who has had close contact with SARS-CoV-2 infected person. So in either of these cases, if you're 12 and over 40 kilos, you could qualify for this infusion. If you would click, please. So I would urge you to ask your pediatrician, your primary care doctor, or your rheumatologist for potential referral for these if you find yourself in either of these situations. Most, it's a 1 hour or less infusion. In our institution, it's set up in our ED, and they have a separate sort of track for it. So there's a process in which your pediatrician has to call, they have to get referral, they have to read some materials to you because it is under Emergency Use Authorization, but it's actually very easy to do. And like I said, underutilized and has excellent efficacy in prevention of hospitalization in these high-risk individuals. So I want you to kind of ask around in your area about the availability of that. Okay, next slide. All right, and this is really the last slide to my piece of this talk. So got questions about protecting unvaccinated children that are not yet able to be vaccinated. And this is a real conundrum. So as you may have seen, the American Academy of Pediatrics has recommended that all children should return to in-person learning because the benefits of that mentally, cognitively, emotionally, socially, really are huge, but they have stated that with caveat that safety is also important and things must be done in a safe way. So there are several ways that they have outlined that I also support and talk to my patients and their families about, ways to mitigate risks and do this in the most safe fashion. And this would include any other activity outside the home or any time spent with individuals that are unvaccinated or higher risk for spreading disease to unvaccinated children. So I recommend, again, I cannot say it enough, but that everyone who can be vaccinated should be vaccinated. So this includes all teachers, all school staff, coaches, parents, older siblings. If it's a shared like K-8 or K-12 school, all of the older students in that same environment. This can create somewhat of a cocooning effect and decreases the risk of transmission. Doesn't prevent it, but decreases that risk to the unvaccinated. So that is really, really powerful and really the best tool that we have. The other good tool that we have is masking. So again, the AAP and other organizations have recommended that all individuals greater than 2 years of age wear masks indoors. And this needs to be caveated by, they need to be well-fitting masks. There have luckily been more and more pediatric size masks produced, ideally multi-layer, so not just a thin piece of cloth, but at least 2 layers. And should not have vents, which was an earlier thing in the pandemic, but thankfully most of those have gone away. So things like children's KN95s or N95s are the optimal, but multi-layer fabric masks are also very beneficial in preventing spreading and also somewhat, intake. Testing is another important thing, and I know different school districts have different plans for this. The more frequent testing, the better. So daily would be the ideal, but obviously there are challenges with the feasibility and cost of that. So that's something you can continue to talk to your school district about, advocate for more frequent testing, or even do in your own home with available over-the-counter tests to at least know what's going on with your own child. And then things like quarantine, contact tracing, and really good communication between the school and parents about potential exposures, keeping kids home if they're sick, which is always good advice, but especially now, even more so than in the past. And then there are other things that are a little bit more far-reaching goals, that things like improvements to indoor ventilation systems. This obviously is not something that's going to happen overnight. We're talking about rehauling, doing construction projects and renovations, but that may be something that's beneficial in the long run to decrease the spread of respiratory viruses for years to come. So something that should be, brought up with your local school district and considered. And similarly, on an individual level, asking for accommodations for your children. Children that are at particular high risk, you can ask that they be seated in the classroom in a certain way to avoid, more frequent exposure. So in a low traffic area, you can request accommodations in the lunchroom to be at a less densely packed table, or even, eating lunch in different times, since that's more or less the highest risk time for these kids when they can't be masked while they eat. So there's a lot of different things that can be done. And ideally, we will be able to vaccinate this population soon, which I think will be a remarkable a time for us all and really make a lot of people feel a lot safer. And with that, I think that is all of my slides.
Okay, I'm going to speak today about what we know about myositis and COVID infection, as well as what we understand about vaccination in patients with rheumatic disease to date. Some information on that from adult studies. So next slide, please. So there have been some publications, and we've anecdotally heard about some patients as well with different manifestations in the muscle following COVID infection or with COVID infection. Probably the most common is that there is frequent muscle pain associated with COVID infection that can result in a high CK level, and an acute viral myositis, certainly a number of cases reported with frank weakness, even back pain, very high CK levels. Most of those patients have been men. There are some reports about breakdown of muscle called rhabdomyolysis, where the muscle breaks down and leaks into the bloodstream, resulting in a very, very high CK level and very dark urine and shutting down the kidneys, leading to kidney injury. Those cases are rare. Similarly, patients developing frank dermatomyositis, all the reports being in adults, and there have been, honestly, in the literature, less than 10 reports to date. Many of the patients have had typical manifestations, but there have been some with atypical presentations with some unusual rashes. Some of the patients have unusually had face muscle weakness, not a manifestation we often see in patients with myositis. And they've had various myositis autoantibodies, MDA5, antisynthetase, HMGCR, MI2. So there have been very varied antibodies, and the patients may have severe illness. We have heard of some patients developing dermatomyositis after COVID infection, both in adults and children, and very few of them have actually enrolled in our studies. We're also working on a study with Mariana Kaplan's group in NIAMS, working on a study to look at COVID infection or patients developing myositis and other systemic rheumatic diseases after COVID vaccine. So looking at the immunology and genetic factors in those patients. There have been reports of paraspinal myositis where there's presumed involvement of the spinal muscles that also can frequently occur in patients with myositis, and that can present with back and or leg pain. And then there have been some reports of myasthenia gravis as well. Next slide, please. So there's starting to appear studies about how patients with rheumatic diseases are tolerating the COVID-19 vaccines. The reports, there are some large series now. Many of them are questionnaire studies done through social media, and I'll present some of these studies now. The first of these reports was from the Johns Hopkins group, and they reported on 325 patients with varying rheumatic diseases receiving either of the mRNA vaccines, Pfizer or Moderna. They reported in a group of a few hundred patients who had received the first dose of vaccine, and they found that side effects were similar to reports from healthy patients from the vaccine trials. At least 69% reported one side effect, one or more side effects, and the most common side effect was fatigue. And as you heard from Dr. Yonts, these reactions usually resolve within a few days. There's a very small study that the advantage of this study is that they compared patients with rheumatic disease, one of whom had myositis, to healthy individuals. It's one of the few studies that compares directly to healthy individuals. And they saw no difference in frequency of adverse events in this group of patients compared to healthy people. Then there was a study from Amsterdam of their cohort of patients with autoimmune diseases, the majority of whom had rheumatoid arthritis or multiple sclerosis. And they also compared to healthy control subjects, and they received really very varied vaccines, the mRNA vaccines, the vector vaccines, even the Chinese vaccine was received by some of these patients. They also reported no difference in adverse event frequency, and they found severe events to be extremely rare. The most common was the local injection site pain, but systemic events were seen in about 25 to 28% of people, with fatigue and headache the most frequent of those. Only 10% of patients had joint complaints, and 5% experienced a flare of their rheumatic disease. Next slide, please. There's another study called VACALUP. This is a study of lupus patients in an international questionnaire setting. They had about half of these patients had received 2 doses of vaccine, and again, it was varying vaccines. Most side effects were mild. Again, a very small percentage, only 3% reported a disease flare of lupus, and of those, about 70% required change of lupus treatment, meaning they were more likely to have a flare that was a real flare, because many of these side effects with the vaccines really do overlap with some flare symptoms too. So it gets to be a little tricky to figure out if it's a real flare, especially in a questionnaire type of study. And then the patients who were flared, who reported flare, they were ones who most likely had a disease flare within the past year. There's another, I think it's an extension of the original Hopkins International Questionnaire study. Now they've enrolled 1,377 patients. They have now they've received both doses of the mRNA vaccines, and about 5% of these varying rheumatic disease patients have myositis. Remember, these are all adult patients. The most common reactions were injection site pain, fatigue as the other most common event. Only 11% reported disease flare requiring treatment, and again, no severe flares. And for those patients, 60% of the flares were after the second dose of vaccine. The flare associations that they found in this study, that patients were more likely to have a disease flare if they had a prior COVID infection, if they flared within 6 months prior to receiving vaccine, if they used combination therapy, which may represent a more active group of patients, although they didn't see a particular association with disease activity. And then patients on specific DMARD therapy or biologic therapy actually had lower frequency of flare. Next slide, please. Okay, there's some emerging literature that particularly started in transplant and cancer patients, immunodeficiency patients, and more recently has been extended to patients with rheumatic diseases, suggesting that there may be lower antibody responses to COVID-19 vaccines in patients who are receiving immunosuppressive therapies, certain immunosuppressive therapies. And then it's a little bit tricky because how low an antibody titer is too low is unclear. We don't know what is a clinically relevant antibody titer. If you have a positive titer, that may be quite relevant enough compared to an undetectable titer. And there's another side to antibody, to the vaccine response. As you heard from Dr. Yonts, it's not just about the response, but it's about how well these antibodies are working against the virus. But there's another side too in the immune system, a T cell reactivity side. And in some of these studies that are studying that, in many of the studies, the T cell side of the response seems to be intact, at least with some of these treatments. So at least a portion of the vaccine response is still there. And these studies are small and early, but what we could conclude so far about these data are that treatments that are associated with very low or no antibody response, I think people are feeling pretty confident about rituximab in the past 6 months. That some people are feeling that after B cells return, there seems to be more of an antibody response. So some people are structuring to, and you'll hear more about this from Dr. Montealegre about when to give vaccine relative to each of these treatments. I won't go into those details. Some other agents that seem to be associated with lower antibody response compared to healthy individuals is one agent is mycophenolate mofetil, as well as methotrexate, prednisone, especially in higher doses, probably, and then anti-TNF therapy. And again, I would emphasize that many of these studies are still small and data is still early. Okay, next slide. So viral myositis and muscle involvement is fairly common after COVID infection, and dermatomyositis has been rarely reported after COVID infection. And we haven't formally heard in the literature, at least, of flares of disease. And I think I've only anecdotally heard of a few patients experiencing a flare of disease after infection. Early studies in adult patients with rheumatic disease indicate COVID-19 vaccines are relatively safe and well tolerated, as well as the healthy population, and disease flare rate is relatively low. An emergence data suggests that there are lower antibody responses to COVID-19 vaccines in patients receiving some immunosuppressive therapies, particularly rituximab, but possibly others such as mycophenolate mofetil methotrexate, prednisone, and anti-TNF therapies. And I think you already heard from Dr. Yonts that our recommendation is to have patients receive vaccination. You'll hear more on this from Dr. Montealegre, and to give a booster dose of vaccine for patients who are receiving some of these treatments or immunocompromised or immunosuppressed, and to also do other protective measures using masking, hand washing, social distancing, and vaccinating the full family or all close social contacts as another way forward. So that's the end of my slides, and I'll turn it over to Dr. Montealegre. Thank you very much.
Thank you, Lisa. So while my slides are being pulled, I just wanted to say thank you to the organizers and also to the presenters to be here, to take the time to do that, but the same for the patients and their families, because it's very valuable that you guys are taking the time to be here, to listen, to take note, and to ask the questions that it will make easier to make an informed decision about how to proceed. So just let me know once we're ready. Most of the things that I will be reviewing has been reviewed already by Dr. Yonts and by Dr. Ryder. So what I will try to do is try to make emphasis in a couple of points and then review the indications of the recommendations from the American College of Rheumatology, for which I will refer as the ACR for third dose. You can call it a third dose, you can call it a booster, you can call it a supplemental dose, but basically all of them are the same. So as I have mentioned before, I will be reviewing for you the ACR, the American College of Rheumatology COVID-19 Vaccine Guidelines Summary for patients with rheumatic and musculoskeletal diseases. Next slide, please. It is very important that we kind of know where this is coming from. This is a document that is constantly changing. The first time this document was approved was in February 8, 2021, but has been at least 4 to 5 different versions since then. The most recent version, the one that we will present in today, is from August 19, 2021. What is the purpose of this information? Is to provide guidance. Is what are we doing here? To provide guidance to the rheumatology providers in how to use the COVID vaccine and how to associate the management for these patients with rheumatological conditions. It is very important for you and for your family members that understand that these statements are not intended to replace any clinical judgment. And the modifications to treatment plans must be individualized because all of us were different. So everything will depend in how active is my disease, you know, which medications I'm taking. And that's why it's very important to have this conversation with your primary care provider. Next slide, please. So one of the questions that either Dr. Ryder and also Dr. Yonts has actually addressed is that we got a question, who can, I have questions about my COVID vaccine. Who should I talk? I mentioned here the rheumatology healthcare provider, but these could be extended to your pediatrician, to your infectious diseases doctor, to any pediatrician who is board certified and who will have the most accurate information to share with you. Why? Because there must be a discussion between the patient and the healthcare provider in order to make a shared decision. Dr. Yonts already talked about this, but just to make emphasis about that, it has been shown, studies has been shown and has demonstrated us that patients with autoimmune and inflammatory rheumatic diseases are at higher risk for hospitalization for COVID and for a worse outcome. This is why, as Dr. Yonts has said, everyone that can be vaccinated should be vaccinated. And this is a statement that is supported by the ACR. It is important that we understand that the vaccination has to be consistent with the age restriction given by the Emergency Use Authorization, a term that it was also reviewed previously, or FDA approval. Dr. Ryder also commented about this. If I get vaccinated, would my immune system respond the same to the vaccine? So it is expected that for patients who have autoinflammatory conditions or autoimmune conditions who are on systemic therapy, the type of response will be decreased. In what? In the duration and the magnitude compared when we have healthy controls. And Dr. Ryder also touched about this topic because it's one of the questions that we have. If I get vaccinated, would my disease will flare? And there is a theoretical risk, and Dr. Ryder, mentioned some numbers between 3 to 5%. Again, this is based on questionnaires that have been completed for these patients, and that we can expect some of these patients we have a disease flare. However, the benefits of COVID-19 vaccinations for patients with rheumatological conditions outweigh the weights for potential risk complications. Next slide, please. So this was one of the questions that actually was posted, and I would like to explain a little bit more. This is consistent with what has been explained before. Which vaccine is recommended for unvaccinated individuals? So the ACR, the American College of Rheumatology, is at this point supporting that unvaccinated patients with autoimmune conditions or inflammatory rheumatic diseases are recommended to receive either one of the mRNA vaccines over the single dose of J&J. And the reason for that is because the one is the FDA approved, and is the one that we can actually get a third dose. There is no recommendation in, should I get Pfizer between Moderna? There is no recommendation on one mRNA over another one. So we will touch base about this, but if as Dr. Ryder has also mentioned, the FDA has approved that patients who have that have an immune system that is compromised have been recommended to receive a third dose, a supplemental dose or a booster. So this has been done for the mRNA vaccines, for Pfizer for patients greater or equal than 12 years of age, and for Moderna for patients older than 18. And some people have asked me, some people in the audience from the questions that we received before, they have asked, how soon we have to do it. So the recommended time lapse at this point is 28 days. You have to take into consideration that if I, Gina, receive a dose in December, these 28 days will not fit because my second dose was in December 2020. So I will, if I qualify in this group, I will just get it as soon as I'm able to get in contact with my provider and do it. One of the questions is, should I just try to match the same type of mRNA vaccine that it was given? This is what is recommended, but we understand that these may not be feasible. So the ACR says that a booster dose with an alternative mRNA vaccine is actually permitted. Dr. Yonts commented on this, but I think there is no reason why not to say it again, because if we do things that are expected and have been shown to make a difference, we should continue to do that. Sometimes someone said, I said, we have been lucky because no one at home has been sick. And they said, Gina, we have not been lucky. We have done things the right way. So what is the right way? We should continue to follow all public health guidance. And I will make emphasis the same thing, using your when wearing your mask, covering your nose, covering your mouth, covering your nose and covering your mouth, keep 6 feet apart, and avoid crowded places. If I am a patient with a rheumatological condition, should my household contact undergo COVID-19 vaccination when it is available? And as we have said before, yes. Household members, frequent close contacts from these patients should undergo COVID-19 vaccination, as Dr. Yonts said, in order to facilitate that cocooning effect. That is that we are protecting them because we are protected, so we are actually exposed. The exposure will be decreased. Next slide. This will take us to guidance related to the use and timing of vaccination and immunomodulatory therapies in relation to COVID-19 vaccination in patients with rheumatological condition. Before I start this section, I think it is important that we understand that there was no evidence when this document was published a couple of weeks ago to support that there is a concern with the use of immunomodulatory medications and safety for the vaccine. The guidance that we are reviewing now is considering, given that we want to the intent to optimize the vaccine response. As you will see, the recommendations are very different because the recommendations depends on the type of medication they're using, which route of administration are using. Is different if you are taking medications by mouth, if you're getting medications by an infusion, and also has to take into consideration which type and dose of vaccines you have received. Next slide. So this is a good example. So this is a complicated table. My recommendations is that I will provide some examples to show you how there is no one recommendation for everyone. This is something that you should approach your provider, review which medications are you on, how is your disease doing, and according to that, make an informed decision. What are the recommendations in regards of holding or not holding your medication? So for example, if you are in hydroxychloroquine, and so many patients with JPM with really mild disease can be on liopraquenil, there are no modifications required. But things start to change when we talk about mycophenolate or CellCept. Dr. Ryder was making a comment about that, and the recommendations for that is to hold for 1 week following each vaccination. Not all the medications, the recommendations are the same. So let's pay attention to this. Methotrexate, what we will have to do, or we will recommend, or the ACR recommends, it will depend on what type of vaccines you're getting. So for example, if you're getting one of the 2 mRNA vaccines, this is either Pfizer or Moderna, you will have to hold the methotrexate for a week after each dose. Is different if you are getting a single injection, a J&J hold methotrexate for 2 weeks after a single dose COVID vaccination. For JAK inhibitors, it's similar to methotrexate. When you get a Pfizer or Moderna vaccine, you will need to hold your JAK inhibitor for 1 week after each dose of the vaccine. In regards to abatacept, is also associated if you are receiving Orencia subcutaneously or you are receiving Orencia IV, and these are the indications that can be reviewed with your provider, and most of the modifications are related only with the first dose. But it actually changes. If you are receiving abatacept subcutaneously, you will have to do it for 1 week prior to the vaccine and 1 week after the first dose of vaccine. There is no changes about when you're getting the second vaccine dose, and it's different from abatacept IV. So if it is IV, instead of 1 week, you will have to do 4 weeks after the abatacept infusion and postpone the subsequent abatacept infusion by 1 week. So, we can go through each one of them, but I think what it will be best is that if you are in any of these medications, it will be important for you to review these recommendations with your rheumatologist in order to make a decision, an informed decision about how to proceed. Next slide. So this will take us about the booster doses, and this is more at this point generalized, but things may change because, again, people are making these decisions in the data that is available, and the data that we have available now is still has some limitations. So this is another thing that is important for you to remember. What I'm saying today may be changed in 3 to 4 weeks. So it is important that there is always, a channel of communication with the primary care provider. So for the supplemental dosing, in regards to immunomodulatory therapy, except for glucocorticoids and anticytokines, we will have to hold all immunomodulatory medications for 1 to 2 weeks after the booster vaccination. And all these assumptions are being taken in the context that the disease activity of each patient allows to make this determination. And again, this needs to be discussed with your primary care provider. And also for rituximab, they also recommend that we will have to talk with the rheumatology provider because, as Dr. Ryder said, it depends or not if some of those CD19 counts are available. It will depend on those numbers where you can receive your supplemental dosing. Next slide. I think that's my last slide. Thank you.
But questions from the chat. So someone asked about the Mu variant and whether there's vaccine protection or any impact on the vaccine's protection. And at this time, we don't know the answer to that question. What we do know, and for those of you that may or may not have heard about it, Mu is another variant of interest that has been circulating most highly in South America, in a couple South American countries, is relatively low prevalence and actually decreasing elsewhere in the world. But the reason it's interesting and concerning is that in studies of blood from individuals that have either had COVID before with a different variant or have had the vaccine, there wasn't as much in vitro neutralization of the virus as we would expect. So all we know right now is that in the lab, in using blood from other people that should have immunity, it has a decreased effect. But we don't know anything about the actual clinical protection as a result of that at this time. Going to the second question regarding Regeneron and children 12 and over. I don't know, but at this point, given that that's been the EUA, I think that's what would be approved first, and potentially with extension, to younger age groups under EUA, but I am actually not familiar with what processes and studies they're doing in younger individuals. And then thirdly, the question was, do the trials for children under 12 years include immunosuppressed children? And unfortunately, they do not at this time. They have been generally healthy children, and having an immunocompromising condition or being on immunosuppressive medications has been an exclusion criteria from the trial. However, I will say that at least Pfizer, and I suspect Moderna and some of the other studies have already started the conversations about doing clinical trials, at least immunogenicity studies in immunocompromised children, sort of once the first phase of studies are done. So that is something that's in the pipes, in the plan, but for the initial trial, it was just healthy children.
Is I have a child who has been in remission for a few years, concerned if it is safe to give her, or does the risk run for her to reactivate her autoimmune disease again? Any thoughts?
Right. So we don't have any studies about people who have been in remission and receiving the vaccine, and could it come back? I think the only data we have are about these patients who already have active disease, or we assume they have active disease. That they're mostly patients under treatment, most of them, not all of them though, and that the flare rate with those patients has been very low. So I think we're comfortable, certainly, and certainly the ACR is recommending that patient, your daughter, would get vaccinated when the vaccine is approved.
Thank you. There was, I think there was some comment from Suzanne saying my daughter has been in remission for 6+ years, and both the 2 doses of Pfizer, and she's fine. So thank you for sharing that. I don't know, because it's true, we review and we can make an emphasis in some of those questions more than one time. So I don't know what will be best for the audience. What do you think, Lisa? We can go over them.
Sure.
With the questions.
Yeah, if you want to start at the top, Andrew, we'll just go through them again.
Yeah.
So, when will the vaccine be ready for children under 12? From Dr. Yonts' projection, she's hoping shortly after Halloween. And I've heard that also from the American Academy of Pediatrics, although I've heard from FDA that it could be a little bit longer than that. So I think, as you heard, there's some uncertainty about all the data that will be coming in and how quickly they can review that. So we're expecting somewhere between Halloween and Christmas, I would say.
The end of the year, yeah. And something to take into consideration is that if at any point takes a little longer, is because if they need more information, they will ask for it. So we don't have to be concerned if it is taking a little longer. They may need more information to make that decision. So how can I protect a child who is too young for the vaccine? So as we talk about trying to boost the cocoon effect. So how do we do that? Getting everyone who is around them vaccinated. So household contacts, people who is coming into the house, family members, and of course, following the other health recommendations, such as wearing a mask indoors, keeping distance, 6 foot distance. And then the other thing would be avoid, crowded, spaces. Lisa, anything else from that you want to say? And wash your hands as well.
Right. I think at school, many schools are following 3 feet distance, and I think in children that's been by the CDC recommendation, so that's fine. I think it becomes a question of how can you minimize the risk. I mean, look at what your community rate is of COVID, and it does fluctuate. Right now, community rates over all the country mostly are higher, and you can see if you're in a substantial or high category of transmission, you want to take even more precautions. Outdoor activities are relatively safe. So the more time you can spend outside doing things with other people, the better. And not trying to be in large crowds would be something to avoid. Not trying to eat in an indoor restaurant, especially if a community transmission is very high. You would want to try to avoid that. Some children, I think the recommendation from AAP is for children to go to school, and I think we support that, but there will be certain children that be more comfortable to stay home. I think you've heard from Dr. Yonts that there are ways to make accommodations at school to try to even cut back on any potential exposure, like taking a different lunch time or taking it more distant from other children, potentially eating outside. There are different things one could do to try to even protect more at school. But for those who go to school, but some children who are on higher dose medication or having more active disease, particularly higher dose medication, and are not vaccinated, they may be children who may elect to stay home.
My child has regular contact with family members who are not vaccinated. Does that put my child at risk? I believe we kind of answered that questions with the recommendations that we have been given before. And again, the best way to protect your child will be to be able to have people who are having contact with them to be vaccinated.
Just one other point on that is from some new data from certain studies, like with healthcare workers, it appears that vaccination also decreases transmission of the virus, or that's what we can infer. And that is that, in healthcare workers who have been vaccinated and their family members, there's less COVID. That may be one reason is the vaccination itself may be protective.
So the next questions, maybe we can group them in how do we know the vaccines are safe if they were developed so quickly? There is another one that is along the same lines. How do I know the vaccines are safe? And and how do I know the vaccines are safe for a child with JDM?
Just a question about safety. I think Dr. Yonts covered that the vaccines have gone through all the traditional phase trials with large amounts of data in the trials. And then since the trials have been concluded under the Emergency Use Authorization, there have been, hundreds of millions of people vaccinated with these vaccines. So we actually have more safety data on these vaccines than in such a short time than probably any other vaccines we have. I think overall, the signals are that they appear to be safe from serious adverse events, appear extremely rare.
Yeah, and maybe something to also share is that for some people, it's difficult to think that this started, late 2019, and then by March we were talking about a vaccine. But from some of us who has been, exposed to this information early on, investigators and scientists were working as this as early as January 15. As soon as the virus was, they said how the virus was configured, the DNA, people was already working on that. And they were working on platforms that has been used and that have been worked before. So it was not a platform that it was created for this vaccine. Lisa, do you want to comment about that?
I don't know if I have anything more
Okay.
to add to that.
Because I feel that that's one of the questions that I get the most. You know, people they don't have the timeline about what Dr. Yonts was saying and how, you know, the platform that we're using, it was not just created in 2020. You know, it's not something that just came out in 2020. It's something that they have a background. They were working on other conditions, but it was something that it was used for coronavirus when this all emerged. Yeah.
Yes. Okay. Yes. And I think, yeah, these vaccines, if in some sense were in development and just got switched to what they were being used for, so to speak. It was sort of putting them to use, putting this technology to use in this crisis time, if you will, in the pandemic time. And in fact, I think that in the future, we will see many of our vaccines switching to this technology, that it seems to be a very robust and safer technology in many ways. And probably over time, a number of our vaccines will switch to this newer technology. And they'll go through the trials. The path to have the vaccine approved is still the same path, that is the rigorous path that the FDA has always used for safety and testing the efficacy of the vaccine in large placebo-controlled trials, and finding the right dose in children, which is why it hasn't been approved in children yet, because they're really trying to be sure that it's the right and safe dose for children.
Dr. Yonts already addressed that. Does someone who had COVID still needs the vaccine? So the answer is yes. And the reason for that is because even though you can develop, she talked about the quantity is not the same as quality. So it doesn't mean that because you have antibodies, you are going to have the opportunity to fight the infection later on. And as of course, those antibodies also decrease over time. I talked about, does it matters which vaccine brand we received? So per the ACR, and as I have said before, most likely that will change in the upcoming weeks. But for now, they're recommended either one of the two mRNA vaccines, and those are Pfizer and Moderna. It is safe to give my child the COVID vaccine while they're on treatments for JDM. I kind of went through the table. I really think that the best way to do it is to have a conversation with the primary care provider and make the determination based on the guidelines. But Lisa, you said—
I'll make a couple comments on that. And first, the question before, is the vaccine safe for my child with JDM? I think from, again, from all the studies about safety in the general population, and then the emerging studies in thousands of patients with rheumatic diseases, myositis being included in some of these studies. We have a study that we're working on with the COVID Global Rheumatology Alliance, the vaccine study. It was in adult patients, thousands of patients enrolled. This will be the largest study reported on, and we've been analyzing this data all summer, looking at the adverse event profile. And we can see that the adverse event profile looks good for patients with autoimmune disease, and if anything, looks better in patients with myositis. And there's no signal for flare of disease or in patients with myositis particularly. Similar to the other published studies, we're seeing a similar rate, low rate of flare of disease, very low rate. And in terms of the treatments, the vaccine is safe to give while on treatment. And the real question is, though, not about the safety of it, but more about, can your child respond to the vaccine if they're on some of these immunosuppressive treatments? And the ACR, what they're trying to do is have medications held a certain period of time, a short time, because they're trying to balance not having the patient flare with their disease, not hold it too long, but try to give a better chance for the immune system to respond to the vaccine. In most cases, it means holding it after the vaccine has been given, but I think for a bad aseptic, it's actually before the treatment is given, the vaccine is given. Some medications are not needing to be held at all. None of the anti-cytokine therapies are needing to be held at all. And prednisone is not held at all. Non-steroidal anti-inflammatory drugs and hydroxychloroquine are not held at all for the vaccines. And this is still something you would work out with your child's rheumatologist, because it really depends on how active your child's disease is and trying to make the best timing of when to give the vaccine versus, you know, not giving the vaccine. Sometimes we just have to go ahead and give it because the risk of exposure to COVID is higher, and we need to protect from COVID. So it's just all a balancing act and trying to do the best we can to try to get the best response we can from the immune system.
Thank you. I don't know if I missed any other one, but maybe I can go into the last two. Does timing of the third dose or timing of the booster shot matter? So the recommendations at this point is to receive the third dose 20 days after the second dose. But this will have to be taken in consideration. You know, if you receive the dose way before, it will be a discussion with your provider just to receive it as soon as you can, because you're already beyond those 28 days. I'm worried about giving my child the COVID vaccine. Who can I talk with more? I think, you know, if you posted that question and you're here, this is these are excellent resources. Other resources will be your primary care provider, your pediatrician, your rheumatologist, and there are some more websites that they're being shared at this point that you can find useful in order to answer some common questions asked by many of us. Lisa, anything else from your part?
No.
Well, I think that is perfect timing, and thank you so much to the presenters. And I think I just want to emphasize again what Dr. Montealegre mentioned, and that is the ACR document is very much a living document, and the recommendations that the ACR has provided are up to date with the current data. But what is happening, as the presenters indicated, that this data is being continuously renewed and guidance is being renewed based on the new data sets. So I would recommend to anybody that's seeking more data, as the presenters indicated, not only speak to your primary care providers, but also if you're after extra information, the ACR website's continually updated. Likewise, the CDC website is also being updated as the various vaccines get approval, as the age varies for approval status for each of the vaccines. That's also going to be updated.